Hello, all. Welcome to our podcast, The Prescription on Earshot Media. I am your host, Dr. Karan Thakur. Hope you're all safe and sound. In 2020, about 1.5 million people died from tuberculosis. The largest number of new TB cases occurred in the Southeast Asian region with 43% of new cases, followed by the African region with 25% of new cases. In 2018, India had the highest TB incidence of 2.7 million cases and the highest fatality of 0.4 million cases globally. We are home to the largest number of TB cases. In India, 2 deaths occur every 3 minutes from TB. TB is transmitted through the air. It is caused by the bacteria Mycobacterium tuberculosis that most often affects the lungs. It is the 13th leading cause of death and the second leading infectious disease after COVID-19. The world celebrates Tuberculosis Day on March 24th every year. So to spread awareness of the disease, we bring to you this podcast on tuberculosis. And to answer all your questions around tuberculosis, I'm delighted to have Dr. Tarun Sahni, Senior Consultant Internal Medicine at Indraprastha Apollo Hospitals with us today.
Indraprastha Apollo Hospitals presents The Prescription in association with Earshot.in.
Welcome to the podcast, Dr. Sahni.
Thank you.
So let me start by asking about tuberculosis as a disease per se. For a lot of us, especially to those who are probably listening to this podcast, it is a forgotten disease. It is taken as a disease of the old, of yore. But that is not so. But first and foremost, what is tuberculosis?
Tuberculosis is a bacterial disease which is usually transmitted from individuals through the oronasal route. So you would transmit it like we had in the first COVID wave when we said everything was oronasal. So commonest transmission is an oronasal transmission, and the commonest site in which it presents itself is in the lungs. Right. So you have tuberculosis, which is a bacteria. It goes into the lungs, and all your symptoms are predominantly from the lungs, which is a cough with sputum, and then you get night sweats. There is a weight loss. And as you well mentioned, tuberculosis was something which we thought was a disease of the past. But in the recent years, we are finding that we are getting tuberculosis, except that the presentation of tuberculosis in individuals is coming in a totally different manner, which is making it more and more important for clinicians to keep thinking of tuberculosis as a diagnosis in addition to whatever else illness the patient might have. So a respiratory disease by a bacteria predominantly in the lung, having a new presentation in the last few years, making it more difficult to diagnose.
Right. And what does it present itself as? What are some of the common symptoms? You touched upon them, but what should one look out for?
No, so the commonest symptom of when tuberculosis was very, very, very common was having a chest infection, which would mean you would have, cough, you would have sputum. And since the bacteria was all over was in the system, you would have night sweats, you would have weight loss, and you would have an evening rise of temperature. These were the standard, 4 or 5 features of tuberculosis in the good old days. Currently, what has happened is because of the very active immunization program and BCG being administered to all children as soon as they're born, the incidence of pulmonary tuberculosis has come down significantly. So there is a reactivation of the tuberculosis in different areas. So you might have people presenting with bone tuberculosis. You might have people presenting with tuberculosis of the spine. You might have tuberculous meningitis. So the presentation has changed. You might have chest infection, but the presentation would be like pleural effusion. So though we are getting TB, the presentation is totally different. And secondly, which I think you're covering a little later as well, is the coexistence of TB with a lot of other diseases, infectious diseases, like HIV and fungal infections. So those are some of the reasons, but currently it could present as any symptom in any part of the body, and you might eventually end up diagnosing that as tuberculosis.
Right. And how does it spread? What are the common routes?
The most commonest is what we are saying hematogenous, which is, The first was the oronasal cavity. It came in through the air which you breathed, so which is why it was very common in closed communities, low socioeconomic groups. Then it was very common in prisons, concentration camps, where again people who were crowded in train journeys, because these were the areas where they were exposed to the bacteria. So the bacteria would enter through the mouth and nose and then go into the lungs, where it would install itself and spread. But currently what we are finding is, though the bacteria is coming in the same way, it is spreading because our immunity is partially strong. So it is spreading through the hematogenous. So it spreads through the blood stream. And then it goes and resides in different organs of the body and presents in a different manner. So oronasal, and then through the blood.
But the bacteria is the same, whether you get a spinal tuberculosis or a pulmonary tuberculosis, the causative agent is the same. Is that correct?
The causative agent is the same. It's Mycobacteria tuberculi. But in recent times, what we are finding is a lot of these infections have a co-infection with what we call atypical mycobacteria. And these atypical mycobacteria, which are mycobacteria or tuberculosis looking like bacteria, their response to the antibiotics is much different. And that is why it is becoming more and more difficult to treat them, because they do not respond to the standard regime of anti-tubercular treatments. So it is the same bacteria, but there is a lot of variations coming in. And I personally believe a lot of resistance coming in to the same bacteria.
Right. And what age categories or groups of people are most vulnerable to it?
I think, that remains the dictum of the past. So if you had, chronic lung disease, you were a smoker. And I think maybe now we can even say if you had COVID and your lungs have been damaged, then you are definitely much more prone to be able to pick up the infection. Having said that, otherwise, there are no specific age groups. You're having young kids with, bone tuberculosis. You're having grown-ups with, TB in the spine or presenting as TB meningitis. So there is really no distinct age group which is more predetermined. People with comorbidities whose immunities are low are definitely much more prone to get Mycobacteria tuberculosis and the disease called tuberculosis.
Right. And you touched upon the correlation with other disease cohorts, and one was HIV. So what is the correlation between TB and HIV?
Well, so I think, interestingly, when HIV was, initially discovered, and they realized that not only was the incidence of HIV going up, but the incidence of TB was going up. And then came in this HIV and TB. Again, the logic being the same, that, HIV was, weakening the immune system of the individual. And since the immune system was weakened, you were much more likely to pick up infection, which you were otherwise strong with.
Right. So it's like an opportunistic infection on top of what you have.
There's an opportunistic infection because your immunity is weak. Similarly, if you've had cancer or you've been on chemotherapy, drugs or radiotherapy, when your immunity is low, or chronic diabetics whose immunities are low, these are the people who are more likely to be exposed and are likely to get TB as an infection.
Right. So you touched upon smoking. I mean, this is a dictum of the past, you said. But some data suggests, there's a data set out there that in 2020, 0.73 million cases of TB were attributed to smoking, while 0.74 million were attributed to alcohol use or abuse. Is there a correlation between alcohol and TB and smoking and TB?
So, I mean, probably not a direct correlation, but if you take alcoholics, chronic alcoholics are usually accompanied with malnutrition. They have too much of alcohol and they don't have enough nutrition in the body. And that makes them prone to not only tuberculosis, it makes them prone to a whole bunch of infections, including intestinal infections. So the correlation between alcoholics has got to do with poor nutrition, leading to poor immunity, making you more susceptible to infections. As far as smoking goes, as I mentioned, the route of entry of the bacteria in most of the cases is through the oronasal cavity. And if you've been a chronic smoker, your natural immunity of the respiratory tract has been weakened. The smoke repeatedly has reduced the immunity which your mucous membrane in the nose, in the throat, in the lungs was there to prevent it. Chronic smoking would have taken that immunity away, making you much more vulnerable to get tuberculosis. So that is why the correlation between the two.
Right. So there's HIV, there's malnutrition, there is alcohol abuse, there is smoking. And what about conditions like chronic conditions like diabetes or hypertension? Do they have any correlation with TB?
I mean, I don't think there's anything directly with hypertension, but diabetes, yes, because diabetes, if it is not well managed, then it predisposes to all infections, including tuberculosis. The other group is people who are on immune suppressants. So you got people with connective tissue disorders, rheumatic arthritis, rheumatoid arthritis, SLE. There are some kidney diseases which require you to be on long-term immune suppressants. Now, these are again comorbidities which make you prone to all infections, and especially tuberculosis, because the moment you're exposed to it, your body clings to the infection. And unlike other infection, it takes a much more longer time for us to treat and get rid of the disease. So all
Right.
comorbidities which weaken your immunity will cause you to be more prone to picking up tuberculosis.
Right. And like in the case of COVID, we saw that if you have COVID, you can be a risk to others by spreading it. Is that the case also for a person who has tuberculosis?
Currently, the infective form of tuberculosis is pulmonary tuberculosis. So you can have a cavitary lesion with TB in it. Because of the immunization which has been done with BCG, at all age levels, moment you're born, we are finding that the incidence of pulmonary tuberculosis is not as high as extrapulmonary tuberculosis. The pulmonary tuberculosis means the one which is affecting the lungs. If it is affecting the lungs, some of those patients, not all of them, some of them patients may have sputum which they are expressing out. And when the sputum is sent for testing, so I would say, maybe less than 10% of the patients with tuberculosis currently are actually actively throwing out the bacteria to be able to affect you.
Right. And then how do you diagnose a person having tuberculosis? What are some of the tests that are done?
The gold standard for tuberculosis testing is what we call an AFB smear. That is an acid-fast bacilli. So if you have a bad cough and you have sputum, we will ask you to give a sample of the sputum and send it to the lab, where they will put it on a slide and they will identify the tuberculous bacteria on it.
Right.
That is the most reliable and the most confident way. The other tests are what we call a Montu test. Montu test is, injecting a small vaccine on your forearm, and you observe it for 48 to 72 hours. If the reaction is severe, it means that you could be having the tuberculous bacilli. You now have gene tests, which like the COVID test, you can actually do what we call a gene expert for tuberculosis, which is much more reliable. And that could also give you an indication that the individual has tuberculosis. So there's a blood and sputum test. Other indirect tests are X-rays. You can do an X-ray of the chest, X-ray of the bone, but those are only indirectly giving you a differential diagnosis that this could be tuberculosis.
Right. And
So
are
only
these tests easily available? Can anybody go and get them done?
The National Tuberculosis Program, which the government has been running for so many years, has an outreach to almost every village, if I might say. So these tests are easy to do. They're readily available and they're inexpensive.
Right. And what about treatment modalities? I believe there's a very specific treatment, and one must follow it till the end for it to be effective. Could you just talk a little bit more about the treatment aspect of tuberculosis?
The treatment is standardized. What we are finding is, so it's basically a 4-drug regime, which has to be taken for usually 6 to 9 months, depending on where the tuberculosis and how severe it is. And these drugs are available at all government dispensaries and all government health centers. They are inexpensive. The government had also floated a program called the Directly Observed Tuberculosis Regime, what they call the DOTS program, in which all patients who were diagnosed with tuberculosis were asked to come in twice a week to the TB center and take the drugs in front of the healthcare worker to ensure that these drugs were well taken. So it's a 4-drug regime. All drugs are easily available. They're not expensive. And the average duration is 6 to 9 months. So the main area of caution currently is that if you have been advised to take your medications for tuberculosis, you should take the entire course. A lot of patients get partially well, and after 2 or 3 months, they lose interest and they stop the medicine. The bacteria could still be in your body, and this leads to what we are calling multi-drug resistant tuberculosis, MDR-TB. So if you have a MDR form of tuberculosis, then the amount of drugs which you have to take are much more toxic. And secondly, you have to take them for a much more longer period of time. So a word of caution, if you have TB, please take all your medications as advised by your government or your doctor and take the entire course of treatment.
Right. And there has been a lot of talk about the abuse of antibiotics leading to AMR, antibiotic, antimicrobial resistance. Does AMR have a bearing on TB as well?
I think all antibiotics which are being prescribed, this is relevant to them.
Right.
Because if you do not use the appropriate antibiotic for the appropriate period of time, you are giving the bacteria a chance for it to mutate and come into a form which is much more resistant than the previous strain.
Right. And now if we turn our gaze to COVID-19 and its relationship or the impact it's had on tuberculosis, with the ensuing lockdowns and also a lot of uncertainty, many patients who may have had a tuberculosis diagnosis in other times did not access healthcare facilities or decided not to go out of fear of contracting COVID or otherwise. Are you seeing an upsurge in the number of cases of tuberculosis now because of the lockdowns and the period that we've had in the past 2 years?
I don't have reliable data to go back on, but in our own practice or in the institution where I work in, I do not think we've had a higher incidence of tuberculosis due to underreporting. And I also have a feeling maybe COVID was a double-edged sword. You know, it stopped people from mixing with each other. It stopped transmission of disease. So maybe it helped stop the transmission of tuberculosis as well. But I haven't seen, I think even within my colleagues and within our group here, I don't think we've seen a higher incidence of tuberculosis because of COVID. Maybe it's the same or maybe it's a little less.
Right. And since COVID was so high impacting on the lungs and the respiratory system, a person who has had COVID, does he or she become more susceptible to now developing tuberculosis and hence should take some precautions?
In the second wave, which is, with the Delta wave when we had the infection, a lot of young adults were left with fairly, damaged lungs. Most of them would have recovered, and I think more than 90% have recovered and their lungs are back to normal functions. But there is still a small residual percentage of people who still are not fully functional because of the respiratory compromise because of COVID to the lungs. Some of these people are definitely more susceptible to all lung infections, including tuberculosis. So they definitely do need to take caution and precautions to prevent it from going any further.
And you touched upon this a little earlier. We've got a good vaccine coverage in terms of our Indradhanush plan, where we cover children for various diseases, including the BCG vaccination, which covers tuberculosis. But we still do find a lot of cases of tuberculosis in children. Why is that so? And is the disease any different in children than in adults?
The presentation of the disease is no different. Children tend to mingle, much more closer in groups, especially if you're studying in schools and you're, in playgrounds, which of course was not there for the last 2 years. But now, gradually, as they get back to their normal routines, they would be sitting in close quarters with each other, eating, drinking, laughing, jumping, playing. So that increases the possibility of one child having a disease and transmitting it to the others. So there is a higher tendency of transmission of disease in the children, and children technically are also not yet fully immunity-wise strong. So they are still a little immune compromised. So they are more susceptible to it, but the presentation of the disease is as similar as it is in the adults.
And what about treatment modalities?
Treatment also is the same. I mean, the drugs are the same. The dosages change based on the age of the individual, because the drug dosages are calculated based on kilogram per body weight. So based on the kilogram per body weight, the dosages of the drug change. Otherwise, the drugs are the same.
And if a child does have tuberculosis and is undergoing the treatment regime, can they go to school and can they still play around, or are there some restrictions that you would recommend?
As long as the doctor who's treating them is confident that he is not an open case. An open case basically refers to somebody who is actively throwing out tuberculous bacilli when he coughs at any given time. Yeah. So if he is not actively spewing out bacteria, then there is nothing stopping him to going back to school and playing there. He does need good nourishment for him to recover from the disease, but otherwise there is nothing else stopping him. There's no stigmata attached to it.
Right. And I mean, this discussion obviously leads to one obvious question, which is how can we prevent tuberculosis or from getting tuberculosis?
I think one, of course, is making sure that the immunization program is good and everybody is immunized. Secondly is, if you're diagnosed tuberculosis, compliance of treatment is the most critical step to prevent further transmission of the disease. Because a partially treated tuberculosis patient is simply to transmit that disease in the community, and that needs to be stopped. Right. Third part, which is now almost become part of our protocol, is to wear a mask. I mean, even if you went to some of the international destinations like Japan, even many years ago, they would always be wearing a mask. So I think masking is not only relevant for COVID, it's relevant for a lot of oronasal transmittable diseases, which can be stopped by just using a simple mask.
Dr. Sahni, thank you so much for coming on to this podcast and enlightening us on the subject of tuberculosis.
Thank you. I wish everyone a very healthy year ahead. And I know we've got the World Tuberculosis Day, and let's hope we can reach a stage when we do away with tuberculosis as a disease, like we've done with smallpox and sort of other infectious diseases in the past.
Thank you. And on that optimistic note, that was Dr. Tarun Sahni from Indraprastha Apollo Hospitals, who joined us for this episode of The Prescription. Do encourage your friends and family to listen to our podcast on Earshot.in or the Earshot app. It helps our tribe grow. Till the next episode, stay happy and healthy.
Indraprastha Apollo Hospitals presents The Prescription in association with Earshot.in.
Earshot, here and now.